Well, good evening, everyone. This is Dr. Jeff Horowitz, and we're here to do take 2 of increasing positive outcomes for Like-Cure Direct composites. I say take 2 because as those of you who were on last Tuesday realize, we had a little bit of a technical issue, and it was as much a shock to me as it was to you. The guys on the Viva Tech side, they did everything they possibly could. Unfortunately, we had a global outage of the Microsoft Cloud is what we've learned. And so it wasn't just us, it was everyone out there who seemed to have some problems as far as webcasts, podcasts, etc. So anyway, for those of you who were here last week and we got cut off in the middle. We all apologize for that, but good things come to those who wait, and I think we've got a really good webinar in store for you. So the theme for today is just achieving more predictable restorations. I'm actually a mentor and scientific advisor at the Coyce Center. I'm not going to go through all my qualifications, but as such, one of my goals in all dental therapy is to reduce risk, not only to the patient, but to myself as well. And so a lot of what we're going to be talking about today is going to be how do we reduce risk? That is, we want to do restorations that last a long time. We don't want to have to be redoing restorations all the time. So we're going to be looking at it from that perspective today. At the bottom of this slide, what you'll see is my email address, jhorowitzDMD@gmail. Please feel free to reach out to me after the webinar, perhaps if I'm unable to get to your question, perhaps if you have something that you think of after the webinar goes on. Actually see that one of my old high school classmates is on, so that's kind of exciting for me. And why don't we take it from here? So before we start, I do want to give a little bit of disclosure here. I'm also a member of the Catapult group, Catapult Education. We're a group of key opinion leaders that test products for many companies. It's one of the reasons that we come to understand so many of the nuances and so many of the good, the bad, and the ugly things that we find with some materials and products out there. The great thing about being a member of Catapult is we get to try all these products, and it's only those products that we absolutely love that we will talk about, whether it be in a webinar or in our live education forums. So I'm just one of the many. There's a whole bunch of these speakers. I'm sure you've heard some of them in the past. And in doing this, we do have to let you know that most of our programs are supported by some of the companies, some of the producers of dental services and products that we use and try. And again, it is only those products that we use and love in our own practices that we will talk about. And what you're going to find at any of my lectures is I very often talk about GC America products because I am a big fan from everything having to go from prevention all the way through to treatment and then keeping patients from coming back for future therapy. It's not just a glass ionomer company, as you're going to see. So let's move on and let's talk about what you came to hear me speak about. Problems related to resins. Now, this is a common problem for all of us. We've all seen the class 2 resin that doesn't last as long as we would like it to. Well, why is that? Typically, it's due to these 5 factors. It's due to microleakage. It's due to shrinkage or shrinkage stress. It could be incomplete curing. It could certainly be structural compromise, as we're going to spend a good bit of time talking about. And very often, it can be a factor of time. We all know that it is very difficult to place a well-performed class 2 resin in a short amount of time, making sure that we don't have any of the other problems you see here. Shrinkage and shrinkage stress, microleakage, incomplete curing, to do all these things right, it does take a strong commitment of time. So there are some products that have been released that have helped us to take away some of that time factor and maybe make some of these things a little less burdensome for us so that we can get a more predictable restoration without having to kill ourselves. We know that if we fail in any of the 5 areas to the left, that we're very likely to see recurrent decay, the #1 reason for failure of class 2 resins. So let's move on and talk about each of these areas individually. So microleakage. We know what microleakage is. It's just leaking in at the filling material interface of fluids, bacteria, molecules, and ions. Anything that can get in between that interface constitutes microleakage. And we know that the more amount of microleakage we have, the larger the marginal gap that we have, the more likely we are to have recurrent cavities. So how do we prevent that? Well, we're going to talk to you about that today. Shrinkage and shrinkage stress. We know that shrinkage is a common problem. There is some amount of shrinkage with every composite resin that we place. We know that associated with shrinkage are shrinkage stresses that can put forces on the tooth and on the sides of the preparation that can create either discomfort or a breakdown in the interface of the restorative material and the tooth. There's a lot of reasons that we have shrinkage. We can definitely improve shrinkage by paying attention to our light curing, but mostly it's inherent in the materials that we're using. And most shrinkage percentages for many of the resins that we're currently using are in about the 2 to 3% range, although the literature shows that many resins are out there from anywhere from 1 to 6% in total shrinkage. Now, the other thing that I want to talk to you about today is something that we don't often give a lot of thought to, and that is, should I be doing a direct resin with a light cured composite, or should I maybe consider going to an indirect procedure? Well, consider this piece of literature here. This is from Larson, and this has been out there for a long time, since the 80s, as a matter of fact, when my partner Kelly here and I were still in high school. But anyway, in this literature, in this piece of literature, what Larson describes is that once a tooth is compromised, that is, once the buccolingual width of the preparation of the tooth exceeds 1/3 of the distance, the intercuspal distance. So if you drew a line from the buccal cusp, as you see here, let me turn my cursor on for a second. So from the buccal cusp to the lingual cusp, if you look at that dimension, any time you prepare the tooth, and that accounts for more than 1/3 of that buccolingual distance, intercuspal distance, we know that it will take half of the amount of force to then break down or fracture the cusp. And that's because of a concept called cuspal flexure. So this is really the line in the sand in my office, and it's something that I think you ought to consider as well, is that once you start getting beyond 1/3 of the buccolingual intercuspal width, once you start preparing, whether it be an MOD or even just an occlusal, you'll see that the numbers don't vary that much. But when we tell our patients that it'll take half the amount of force to cause an inherent fracture in the tooth, many of them will ask if there is a better procedure that they can be doing. And at that point, we will do a cuspal coverage procedure with an indirect material such as Ceresmart. And Ceresmart is my absolute go-to for my inlays and onlays. It's a material that I use in a lot of my bite rehabilitation cases. Why? Because of the very flexible nanoceramic matrix structure. It has a lot of give. It's very forgiving. So even though we have that makeup of a resin, we have that nanoceramic matrix in there, which allows for better polishability, and we get a beautiful looking restoration, but it's also a very forgiving restoration. So I know you didn't come to talk about indirect restorative, but I think you should be aware of this product. It can be done on your own CEREC machines or milling in your own office, or it can be ordered from the laboratory if you prefer to do this indirectly. So assuming that we're going to do a direct light cured composite, we're going to look at one of the biggest reasons for failure, one of the biggest reasons for incomplete curing that we know of, which is operator error. And that's very unfortunate because this could be under our control, but it can also be difficult at times. So let's look at curing a little bit more closely, because more often than not, this is what's to blame when we don't get full polymerization of the resins that we're working with. So this was first described by Dr. Richard Price. These are the core variables in light curing. And so when we think about photopolymerization of a restorative material, we have to think about these four key components. The first is the curing light itself. How is the curing light made up? What wavelength is being emitted by the curing light itself? What condition is the light in? Has it been maintained well, and is it being overseen? Certainly second is the operator's technique. So imagine that you have an assistant that has this curing light sitting over your restoration. You tell them to go ahead and cure, and they're looking away so that they don't see the blue light, which is obviously a good thing. But as they sit there, the light starts to move further and further and further away. Or perhaps you're using a matrix system that makes that light sit further away from the cavo surface. Angulation, undercuts. There's so many reasons that that light will not be able to be emitted right at the cavo surface. And we'll see that all of the research that's done on our materials and the restorative characteristics that are explained to us in the directions for use, they all assume that the curing light is sitting right at the cavo surface margin or within a millimeter of it. So please consider that that's not where your light typically is when it's in the mouth and we're curing in a real human being. The other thing that we have to consider is what are the characteristics of each specific type of restorative material. So some materials out there will talk about having curing depths of 6 or 7 millimeters, which I caution everybody about, because by the time you add your distance with the curing light, the likelihood of filling a really deep restoration and getting it fully polymerized, especially if we go into a darker color or we overfill or don't measure the proximal box, there's just a lot of reasons that we have to be really careful understanding the recommended curing depth for the restorative material and then giving ourselves some playroom. So if it says 4 millimeters, that means that they probably allowed for about 5 millimeters away for curing. But if your box is going to be deeper than 4 millimeters, I certainly wouldn't try to build it up all in one bulk fill. So the last thing is, what is the energy requirement of the composite resin, which would have to do with what type of a light, what type of wavelength are we using in the given light system that we have. So I just want you to pay very close attention to what you're doing with your curing light, because very often this is the difference between good and bad photo initiation of the restorative material. So the important thing to get from this slide is that when we look at the energy and the guidelines set forth about curing lights, we talk about ISO performance. That's how they're measured. And when we talk about what ISO performance really tells us, it's telling us what's happening directly from the light tip to the restorative material, and it is not assuming that the light could be further than 1 millimeter away from the tooth structure. So always keep that in mind when we talk about ISO performance. Let's move on. Let's talk about what poor performance in any of the 5 areas that we just talked about is going to lead to. It's going to lead to recurrent decay. What does recurrent decay look like around a Class 2 composite? Typically it looks like this. It's breakdown at the cavo-surface margin, usually somewhere within the proximal box, starts off as micro leakage and then manifests itself as recurrent decay, as you see here. So what are some of the things that we can do to overcome these obstacles? Well, first, we can use high-quality materials. One of the things I know about GC America, having worked with them for a very long time, and again, I do not receive anything from GC for any sales of any of their products. I am merely a user of their products. I've tested a lot of their products, and I happen to be a big fan of the quality of these materials and their dedication to research and development. And so when we start talking about materials that are going to reduce our future risk with our bulk fillable light cured composites, this is a material that really has gotten my attention. So this is a bulk injectable composite. It's got a really nice viscosity. It handles beautifully. What I really like is that it adapts very well to the walls and to the cavo surface margins, and it is a bulk fill material, which can be a time-saving factor. There's some really interesting things about this material, and that is that it is a very high density resin that is now covered completely with this silane coating. And what that creates is this really homogeneous matrix of nanoparticles, which allows for great polishability while still allowing for really high strength and low shrinkage, as well as good adaptation to the proximal box. So let's talk about this in a little bit more detail. So first, one of the nice things is it doesn't tend to stick to the instrument. It has a really nice radio opacity, so it's easy to identify on radiographs. It's got a nice viscosity, but it also is thixotropic, meaning that we have some shapeability. It's very, very easy to manipulate once you put it in, especially when you compare it to other flowable materials. It has a depth of cure of 4 millimeters, and you can confidently do that a millimeter away from the tooth up to about 5 millimeters. I'd be very, very leery of going beyond that 1 millimeter away from the tooth. So if your proximal box is deeper than 4 millimeters, I wouldn't do it. I'd also be very, very careful about what many manufacturers say with 6 and 7 millimeter depth of cure, because that also doesn't account for things like angulation, undercut, and many other issues that lead to poor photopolymerization. So, but for many cases, this means that there's a one-step filling process. Pardon me, went one too far. And we do get really nice adaptation to the cavity. But it's not that I'm just going to take someone's word for it. As I said, very often as part of the Catapult group and testing products for many of the manufacturers that are out there, I want to try this out for myself. I want to see what this looks like when the rubber meets the road. So when we got the literature at first, I did read all about it, seeing that it was a high-density resin, very interestingly covered with a full silane coating. That allowed the silane particles to disperse. We had a very homogeneous mix, very high-density mix. So it gave us a nice combination of both strength, wear resistance, and improved handling. So again, that's what they wrote, but was it really going to perform that way? It has very good flexural strength and good gloss retention. Why? What is the difference between a nanoparticle filler and a large filler? Is that when we get a break at the surface or breakdown at the surface, when a large particle filler falls out or breaks away, chips away, that leaves more surface roughness and will have less gloss and a higher likelihood both for plaque retention and for loss of polish and surface roughness to the tooth as well. Certainly better marginal integrity. When we look at this product, we have to talk about strength and wear resistance because of those smaller particles that are encased in that silane coating, and they're very evenly dispersed, so any small breakdowns at the margin typically are still going to leave you with a very resistant and very polishable surface. So you can take a look at these graphs comparing to many of the other materials that are out there with a lower risk of chipping or fracture, also providing a very high and durable restoration. We also can compare it to many of the other materials out there for depth of cure and radiopacity. As far as both go, they are certainly in a similar range to everything else that's out there. Again, I am always very leery of the deeper depth of cure materials, especially because the deeper the box gets, the more likely we are not to cure a restoration because of angulation or because of distance away from the cavo-surface margin. So keep that in mind, but typically we're seeing a nice radiopacity as well on the radiographs following. What does separate this a little bit was the high shapeability. The R&D department, when they were working on this material, was really looking for something that would not only flow easily into the preparation, but that could also be dragged so that the clinician was not having to run over it as much with the burr, spend as much time with the shaping burrs. So you can see in these photographs here that we're able to drag the material around and as you see here, not have to cut away as much flash. Just makes for a little bit of shapeability, which is not often seen in a flowable material like this. As I said, when any material comes to my office to try, before it goes in the mouth, it goes into my typodont. This is actually one of my typodont teeth at the office. I look like a little boy at Christmas or Hanukkah, if you will. And I go running back to the back office like the nerd that I am. I pull out a typodont tooth. I prep it the way I want to prep it at the right depth and width for a typical restoration that I would be doing in my office. And so what did I do here? I prepped the prep and I squirted it in. Didn't do much other than that. I took a little instrument, didn't have my loops on, took a small instrument, dragged it around a little bit, and I was extremely pleased at the adaptability that I saw when I got to this finish. So I peeled away my matrix, and as you can see, it was an absolute perfect adaptation to these side walls. And I was very, very pleased considering that I didn't really spend a lot of time doing it, that I pretty much just injected it and went to it just as is and peeled it right away. So that was one bulk fill, and with that one bulk fill, we just did a light curing of 20 seconds. I peeled it away, and that's what I had. So I was very pleased. With regard to shrinkage, you're going to see that, as I said, almost all of the materials that we're using out there right now have a volumetric shrinkage, typically anywhere from the high ones to about 3% volumetric shrinkage. They're all very, very close to each other. There are not any that don't shrink at all. Every material shrinks to some degree. So I'm just looking for something in the acceptable range that makes it easy for me to control all of the other factors that have an impact on shrinkage, one of the biggest ones being proper light curing. So we talked about the polishability, we talked about the gloss retention. These are all very positive, and again, it has to do with that homogeneously dispersed filler all encapsulated within that silane coating. So very nice product, and now it was time for me to start getting into some real live application. So I did so, and I will tell you that most large class 1s and most class 2s can be filled in a single application. I will never use the word always, but I'll tell you I did find that it was very easy to use. So here's a pre-existing class 2 amalgam, had some marginal microleakage, had no proximal contact, so I was off to the races on this one. I always say, you know, everyone thinks that you have to pack to get a good contact, and that really isn't true if you're using a really good matrix system. I have several matrix systems that I really like. Waterpik makes a good system. These from Danville, the Mega V and the Contact Matrix are good systems, and certainly the Triodent. Those are all some of my favorite systems out there. I would just tell you, learn to use these efficiently. Placing the ring on for a pre-wedge is never a bad idea, but then certainly followed by a sectional matrix with wedging. We are not using the wedge to push the teeth apart. We are using these bitine rings that are made by all these companies to establish a good contact. And if you're using the right band, the shape should be nice, and you really shouldn't have to be packing your class 2 material the way we thought about packing amalgams. So here was my preparation, and in this case what you're going to see is that we did a selective etch procedure. I am very big on the self-etching primers and adhesives. I'm an old Ray Bertolotti fan, back from when he brought self-etching primers and adhesives, but have always felt that enamel is best served when it's etched. And we know that the data tells us that as well, that enamel will respond better when it is etched. So this is a selective etch with the 8th generation G Premio bond from GC America. And so there's our etch. And here we are using our disposable applicators. Those are also from GC. And what we're doing, I'm sorry for the jump around there. What you see here is the placement of the ring. You see application then of my G Premio bond. That will go on for 15 to 20 seconds, being agitated into the dentin and spread over the enamel. It is very important that you leave this 15 to 20 seconds so we can get an etching of the dentin if you are using this technique. We then went in with our Genio bulk injectable. The prep was filled entirely. The adaptation was very good. We came in with the curing light, and again, full 20 seconds, repeat full 20 seconds, slightly different angulation directly over the tooth, and then we remove our matrix band, and we're going to light cure from the buccal and from the lingual each 20 seconds again. You cannot over polymerize. I can't say that enough. In this one bulk filled class 2 composite, if you'll remember, this patient had no contact, proximal contact on the mesial, and there was an area of micro leakage on the occlusal surface. So we went through our selective etch procedure. We used our G Premio bond, and now we've placed our material in full, in bulk, and now we're going to come in with our finishing. Because it's sculptable, there's not a lot of excess flash that we have to remove, so I'll come in with a extra fine OS1 burr and smooth that off, and then I will follow that up with these ASAP polishers that you see here from Clinician's Choice. I'm a big fan of those. If you want to go even simpler, you could use something like a brownie point, maybe at 10,000, 15,000 RPM with lots of water. That'll also give you a nice finish, though not quite as nice as these ASAP polishers from Clinician's Choice. So there's the final restoration. Yes, it was a little bit light. I only had a couple of color opportunities when I started getting my trial material. So it was a little light. We talked to the patient about possibly placing a veneering composite over that, which is not a problem if you want to, but the patient was very happy with the slightly lighter color, and it was a nice, dense, even mix, nice finish. Everything worked out really well with that restoration. But now, what if you are in a situation where, as I said, you have more than 4 millimeters from the bottom of your proximal box to the height at which the composite needs to be placed on the cavo surface? In this case, you can see that we're at about the 6 to 7 millimeter mark for the total depth of that proximal box. So I would never, in a case like this, want to inject the entire preparation. Why? Number one is we're not going to get full polymerization. There's going to be a whole bunch at the bottom that doesn't polymerize, and then we end up with a situation like you see here. So what will happen here is I have a choice to make. I can use the same material and put it in 2 layers, or I may choose another type of material. So I like to call this the second layer technique. So you have a proximal box that's more than 4 millimeters deep, and so now if my curing light gets more than 1 millimeter away, or if there's an undercut in that preparation, I'm not going to get full polymerization and be more prone to micro leakage. So we're just going to do this one in 2 layers. So this is the tooth in question that you see here. This is tooth number 14. And you can see where this was a large MOL composite. 15 had a large occlusal behind it. 15 was not so deep, so that was able to be treated in 1 bulk fill. But when we look at this, there's our selective etch, application of our G Premio bond. You can see I only got a couple of colors when we started placing this, so I was having to be pretty selective with the cases that I chose. There is our first layer, so basically I just covered the bottom of the proximal box, built it up about 3 millimeters, covered the initial dentin on the pulpal surface, which allowed me then to come back with a second layer that was only 2 or 3 millimeters thick at its thickest point, and that way I could guarantee that we were getting good photo initiation and full polymerization. So there's there you see that the first bulk of the material placed, light cured for 20 seconds, reposition, light cured 20 seconds, and then we come back with our next layer of material. And these are the cannula tips that are offered with the GC bulk material. They're really nice because they're flexible and they're easy to angulate into the preparation as you see it. We come back with our OS1 finishing burr after everything has been placed, after the second bolus has been placed and light cured. So there's our OS1. We'll follow that by our Clinician's Choice ASAP points. And we're kind of off to the races there. So now, what if I was concerned about bioactivity? So I wanted something that would possibly be useful in a high caries risk patient. So someone who has, despite coming in every 6 months, seems to always have recurrent decay at the gum lines, or ends up with a lot of class 5 cavities or new root surface cavities, or perhaps we go on to the route with our Class 2 restoration. Now I'm starting to think about the possibility of using a bioactive material. So we have several options with regard to that. But for right now, we're not seeing anything that gives us the kind of ion exchange that a glass ionomer product does. So this is actually a product from GC. It's just a new take on an old product. It's GC Fuji Automix, light cured. So I could inject a little bit of this material down onto the floor of the proximal box. I could cover my dentin with this, and then I could come back and use a total etch technique, not only etching the glass ionomer surface, but also etching the enamel at the same time. And because I've covered the dentin, I don't have to worry about getting down too far into those dentinal tubules and having to be quite as concerned with MMP formation or sensitivity, as I mentioned. So this is one way of looking at it, using this GC Fuji Automix material. It's really nice. It does not require a capsule of any type if you're not into the whole capsule thing. Has a very nice little mixing tip and cannula, allowing you to get into some pretty tight places. And so this now becomes another option that we put our first layer down with a bioactive glass ionomer, and then follow that up with our G-annual bulk injectable. What is another option for me? I could come in and use another GC product like Equia if I felt like I wanted to have something that condensed a little bit more. I could use my Equia Forte, which is a nice glass ionomer product that will also have a good ion exchange at the cavo surface margin, and hopefully help as a preventative measure for my Class 2 cavities. So here's a high caries risk patient, and we had an MOD, and we're going to first put in our Fuji LC Automix. So how does this go? Well, the first step here is not an etchant of any type. With the glass ionomer products, you prefer to use a polyacrylic acid like GC Cavity Conditioner, and we're going to generously apply this over all of the dentin, scrubbing it in. We're going to allow that to sit about 10 to 15 seconds, and then after that's done, we're going to rinse and dry, but we're not going to desiccate. And now we're prepared to put the glass ionomer product all over our pulpal floor and at the cavo surface, all the way down at the bottom of the proximal box, filling the bottom of the proximal box. This is a light cured material. You could use a self-cured material if you preferred to do so, if you felt like you were going to have a hard time getting the light to go there. So this is the GC Automix LC, leaving space for the veneering composite, which in this case is going to be my G-annual bulk injectable. But again, lots of ways to handle this case, just the way we chose to handle this one. So you see the Triodent matrix system from Ultradent there, and we've placed our first layer of the GC Fuji Automix Light Cure. And now, because all of my dentin is covered and it is not vulnerable to over-etching or over-desiccation and MMP formation, which can actually degrade our bond to light-cured composites over time, now we're going to etch over the entire surface, the enamel, and all of the light-cured Fuji LC Automix, and we're going to come back with our bulk fill. But as I said, if I wanted, I could come over this with my traditional composite in my office. My universal composite is GC Color. Just has a beautiful chameleon effect. I get the best of most properties, polishability. G-annual Sculpt is another fine choice. It happens to have a little bit more sculptability. I tend to prefer a more firm material, which is why I stick with the GC Color, but the Geenial Sculpt is absolutely a beautiful product as well. It's just a little bit softer than the Color is. But we're going to come in, we're going to etch, we're going to place our G Premio bond, we're going to air thin that, we're going to light cure, and then it's back with whatever composite we choose to place. In this case, we came back with the bulk flow. This is my interproximal primary shaping burr, and that's a mosquito, and this is a fine. I might come in with an extra fine followed by a fluted, an ET12 or something on that lines. And then you see in this case we just use the brownie point at 10,000 RPM, lots of water, or otherwise the clinician's choice ASAP polishers that I'm a big fan of. So there's the ASAP polisher as well, just to show you what that would look like. There are two polishers there. There's the purple and then the tan. And those are done at slow speed, and in the slow speed handpiece, again, looking at about 15,000 RPM or so. So again, I apologize for the little bit of fuzz on the picture on the left, but you can see that we got a fine looking restoration there, and very happy with it. And I feel good about the bioactivity that is inherently there because we have the glass ionomer product underneath. So that's really about it as far as increasing your predictability. I think the big takeaway from this lecture is just how important light curing is. Never just assuming because a material says 6 millimeters of bulk cure that you can fill 6 millimeters and hang your light at a bad angle or hang it in an off direction or too far away from the preparation. Understanding the point at which structural compromise can really take away from your restoration, even if it's a bonded restoration, because what we've learned is that through the research, we know that once that buccolingual isthmus width is more than 1/3 of the buccolingual cusp tip distance, that the restoration becomes weaker. We have more cuspal flexure, and we are still prone to fracture even if the restoration is bonded. So just use some discretion on those. You know, when they're exactly 1/3, do I always come in and do an indirect restoration? Absolutely not. It's really a judgment call. It's based on the patient, based on the forces. But typically once it gets much beyond that 1/3 intercuspal width, then what I will do at that point is go to an indirect restoration again with cuspal coverage, because my goal again is to keep my patients out of the chair once I provide any initial therapy for them. The other things that you want to remember, we had structural compromise, we had curing, we talked about microleakage, which with possibly the use of a bioactive material, again relying back on good solid light curing, using good wedging techniques and good bracing, possibly pre-wedging with one of the bind-tine systems like a Triodent, the Danville, or even Paladent makes a nice one, Waterpik makes a nice one, and a sectional matrix. So hopefully we've introduced some new concepts to you. We've given you some things to think about. We've shown you some nice products for you to try that I know you'll be very satisfied with. Again, if you have any questions at all, you can feel free to reach out to me at my email address, jhorowitzdmd@gmail.com. If you'd like to reach out to us at Catapult Education, catapulteducation.com, to see what some of the other speakers talk about or some other subjects. Otherwise, I know you're going to meet more of our Catapult speakers here on Viva Webinars. I'd like to certainly thank Viva Learning, and I'd like to thank GC America for the opportunity to present, albeit we had a couple of glitches here, so but that's okay. We make the best out of it. The same thing happens in the dental chair all the time, doesn't it? We don't always get what we plan for. So I'm going to leave you with this one thought. If you'd like to contact me at a later time with any questions, you certainly may, but I'll leave you with this one thought, that your beliefs don't make you a better person, your behavior does. So wishing you all a good night, and hope to see you soon again on another Viva webinar.